Hello and welcome to the topic Tachyarrhythmias in the Cardiology module. By the end of this topic, you should be able to define tachyarrhythmias, classify tachyarrhythmias based on the origin of abnormal rhythm, outline the clinical features of tachyarrhythmias, interpret ECGs of tachyarrhythmias, identify peri-arrest tachyarrhythmia rhythms, and finally discuss the management of tachyarrhythmias. Let's get started. So, what are tachyarrhythmias? Tachyarrhythmias are largely classified into supraventricular, where the arrhythmias originate from above the ventricles, and ventricular tachyarrhythmias, where it comes from the ventricles itself. Tachy meaning fast or rapid, and arrhythmias meaning abnormal heart rhythms. In supraventricular tachyarrhythmias, the heart rate will be typically above 100 beats per minute and they will begin above the ventricles, which could be from the atria or the nodes. If the abnormal conduction begins in the atria, you would then see atrial fibrillation or atrial flutter. AV nodal re-entry tachycardias, AVNRT, and AV re-entry tachycardias, AVRT, are characterized by the sudden onset of a narrow complex tachycardia which are regular. Let's look at atrial fibrillation. Atrial fibrillation is the most common sustained cardiac arrhythmia. The heart rate in atrial fibrillation is variable, meaning you may have instances where the heart rate can be very fast, causing rapid ventricular response, or at other times they are very well under 100 beats per minute. Secondly, atrial fibrillation shows an irregularly irregular rhythm. That means there are irregular QRS complexes and a loss of synchronous atrial contraction, which is then reflected by the absence in the P waves. A distinction is made between primary or idiopathic and secondary atrial fibrillation. Idiopathic atrial fibrillation describes atrial fibrillation in individuals without any other cardiac diseases and accounts for about 15 to 30% of AF cases. Secondary atrial fibrillation is caused by an underlying disease that may be cardiac or non-cardiac in nature. The most common cardiac cause of atrial fibrillation is a mitral valve defect. Other possible cardiac causes include advanced cardiac insufficiency, coronary artery disease, or myocardial infarction. Among the non-cardiac causes of atrial fibrillation are arterial hypertension, hypothyroidism, or the ingestion of toxic substances such as alcohol, thyroxine, triptans, theophylline, or sildenafil. An acute atrial fibrillation that occurs in an otherwise healthy person after excessive consumption of alcohol is also called holiday heart syndrome. Now, let's briefly look at the pathophysiology of atrial fibrillation. The arrhythmia of atrial fibrillation is caused by a reentrant tachycardia of the atria, mostly around the pulmonary veins. This means that the electrical impulses do not propagate in a normal physiological manner, which is starting at the sinus node, moving through the atria and into the ventricles. Rather, they repetitively move in a circular path inside the atria, which continuously depolarizes the atrial myocardium. This results in an atrial frequency of 350 to 600 beats per minute. Because the myocardium is contracting in an asynchronous manner, the atria can no longer effectively fulfill their pumping function. This reduces cardiac output by 15% in healthy individuals, with an even higher percentage in patients with a pre-existing cardiac insufficiency. And because the AV node acts as a kind of blocker, not every excitation of the atria is conducted to the ventricles. The transmitted, often irregular ventricular frequency ranges mostly from 100 to 160 beats per minute. Now let's take a look at the clinical symptoms of atrial fibrillation. For many patients with persistent or permanent AF, the disease often remains asymptomatic as the reduced cardiac output can be easily compensated as long as there's no unusual strain. However, in cases of increasing cardiac insufficiency, physical strains, or paroxysmal atrial fibrillation, symptoms are more likely to manifest. These include tachycardia with palpitations, syncope, dizziness, an irregular heartbeat, and exertional dyspnea. In addition, patients who do not know what is causing their condition also might react with panic. Clinical examination may be notable for an irregular heartbeat, variable intensity of the first heart sound, and difference between the auscultated heart rate and palpable peripheral pulse, which is known as pulse deficit. However, unremarkable findings do not rule out the presence of atrial fibrillation. Now let's take a look at the differential diagnosis for atrial fibrillation, which is importantly atrial flutter. Both types of arrhythmia show very similar symptoms. They have the form of a sawtooth pattern, and treatment is causal, consisting either in trying to convert the arrhythmia or in radiofrequency ablation. There are two main strategies employed in dealing with arrhythmia element of atrial fibrillation. First is the rate control component, where we accept that the pulse will be irregular but slow the rate down to avoid negative effects on cardiac function. And secondly would be the rhythm control, which is where we try to get the patient back into and maintain normal sinus rhythm. This term is known as cardioversion. Drugs can bring about pharmacological cardioversion, and synchronized cardioversion electrical shocks are also known as electrical cardioversion, which may be used for this purpose. The NICE guidelines advocate using a rate control strategy except in a number of specific situations such as coexistent heart failure, first onset of AF, or where there is an obvious reversible cause. For rate control, a beta blocker or a rate-limiting calcium channel blocker is used first line to control the rate in atrial fibrillation. If one drug does not control the rate adequately, NICE recommends the combination therapy with any two of the following, which could be a beta blocker, a diltiazem, or digoxin. Digoxin is sometimes given to patients with cardiac insufficiency in addition to beta blockers. However, recent studies have indicated that digitalis treatment is connected to a higher mortality rate in patients. As we're talking about rhythm control, first-time AF is usually treated by trying to control the sinus rhythm. Restoring AF to regular sinus rhythm is called cardioversion. And here we can apply chemical cardioversion. Is used for patients without any cardiac disorders and involves administration of drugs, mostly class 1C antiarrhythmic agents such as flecainide. If a patient has known pre-existing cardiac conditions, the more effective amiodarone can be administered, although it carries a greater risk of side effects. For this reason, amiodarone should only be administered in patients in the hospital. If patients do not respond to medication or if there's the risk of cardiogenic shock, synchronized electrical cardioversion can be performed. In this procedure, low energy shocks of 200 joules are given to the sedated patient. Other more invasive options, especially for younger patients, are aimed at destroying the area of cardiac tissue that is causing the re-entry mechanisms, either by catheter ablation or surgery. When considering cardioversion, it is very important to remember that the moment a patient switches from atrial fibrillation to sinus rhythm presents the highest risk for embolism leading to stroke. Imagine the thrombus formed in the fibrillating atrium suddenly being pushed out when the sinus rhythm is restored. For this reason, patients must either have had a short duration of symptoms or be anticoagulated for a period of time prior to attempting cardioversion. Next, let's look at another important component in the treatment of atrial fibrillation, which is thromboembolism prevention. The prevention of thromboembolism in patients with atrial fibrillation is of utmost importance because of their increased risk of embolic events, especially a stroke. This risk is assessed using the European Society of Cardiology's Chair-2-VASC score. In cases of non-valvular AF, a score of 0 indicates a low risk and does not necessarily require anticoagulation. However, even with moderate risk, which is a score of 1 or more, permanent anticoagulation will have to be considered unless the risk factor is only based on female gender. With a score of 2 or more in the risk stratification, anticoagulation is imperative. This table outlines the difference between warfarin and novel anticoagulants for the prevention of thromboembolism. Next, let's take a look at AV nodal reentrant tachycardia. and AV reentrant tachycardia. So AV nodal reentrant tachycardia, here on will be known as AV-NRT, involves a re-entry circuit in and around the AV node. It is the most common form of paroxysmal supraventricular tachycardia, whereas AVRT or AV reentrant tachycardia involves an accessory pathway between the atria and ventricles some distance from the AV node. Some forms of AVRT may exhibit a Wolff-Parkinson-White pattern, whereby an accessory pathway capable of the anterograde conduction leads to pre-excitation of the ventricles. This accessory pathway is a bypass track, therefore avoiding the AV node and therefore the normal delay which occurs at this point. This leads to characteristic delta waves on ECG, whereby there is upsloping at the start of the QRS complex due to the early ventricular excitation. The ECG features that you'd expect to see include P wave being buried in the QRS complex and the QRS complex being less than 120 milliseconds. Next would be Wolff-Parkinson-White syndrome. This is caused by a congenital accessory conducting pathway between the atria and the ventricles, leading to atrioventricular re-entry tachycardia. As the accessory pathway does not slow conduction, AF can progress rapidly to VF. Verapamil digoxin should be avoided in patients with Wolff-Parkinson-White as they may precipitate to VT or VF. The possible ECG features include short PR interval, wide QRS complexes with a slurred upstroke, delta wave, left axis deviation if right-sided accessory pathway, and right axis deviation if left-sided accessory pathway. The associations of WPW syndrome include HOCM, mitral valve prolapse, Epstein's anomaly, thyrotoxicosis, and secundum ASD. As for the acute management, if the patient is compromised, use DC cardioversion. Vagal maneuvers such as carotid sinus massage and Valsalva maneuver can be applied, and IV adenosine is also given, however contraindicated in asthma and allergy. In those cases, you may use verapamil. Long-term management of supraventricular tachycardias include prevention of recurrence of the arrhythmias. This can be done with a maintenance dose of antiarrhythmic, such as in the use of beta blockers. Electrophysiological testing and catheter ablation can be done if there is presence of accessory pathways on testing. Next would be ventricular tachyarrhythmias. And this happens when there's any heart rhythm with a rate greater than 100 beats per minute that starts in the ventricles. Ventricular tachyarrhythmias can be divided into ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia is broad complex tachycardia originating from a ventricular ectopic focus. It has the potential to precipitate ventricular fibrillation and hence require urgent treatment. There are two main types of ventricular tachycardia, which we have the monomorphic type, most commonly caused by myocardial infarction, and polymorphic type, which is a subtype in torsades de pointes, which is precipitated by prolongation of the QT interval. Let's look at monomorphic ventricular tachycardia. This is a regular wide complex tachycardia with an ectopic beat that originates from the ventricles. There is a risk for hemodynamic collapse and sudden cardiac death in all patients with ventricular tachycardia. As for polymorphic ventricular tachycardia or torsades de pointes, a ventricular tachyarrhythmia with a rapidly changing rate and rhythm. This rate can change between 150 to 250 beats per minute, and the amplitude also changes when observed by ECG. This arrhythmia may spontaneously revert to normal or progress into ventricular fibrillation. Next, we have ventricular fibrillation, which is a most severe ventricular tachyarrhythmia, and in this arrhythmia, the ventricle rapidly and sporadically beats. The ventricular heartbeat is uncoordinated, resulting in immediate hemodynamic collapse. Death is likely within minutes unless advanced cardiac life support measures are started immediately. We have the most common cause of VT, which is ischemic disease, often after an MI. Scar formation via surgery or infiltrative cardiomyopathy due to systemic inflammatory diseases such as sarcoidosis, amyloidosis, and hemochromatosis also increase the risk of VT. Coronary artery disease is a major risk factor for VF, and extensive coronary artery occlusion is the most common pathologic finding. Restoring coronary artery flow has demonstrated a reduced risk for VF. Dilated cardiomyopathy increases the risk of VF. It is the most common type of non-ischemic cardiomyopathy and is associated with ventricular remodeling and an increased ventricular volume. Hypertrophic cardiomyopathy is frequently a genetic disorder which is autosomal dominant in nature and also increases the risk of VF. Then we have Takotsubo's cardiomyopathy, increasing the risk for developing Torsades de Pointes. Takotsubo's is associated with acute heart wall weakness and is often associated with severe stress. Some patients have a naturally long QT interval. The QT interval is measured on an ECG strip from the start of the Q wave to the end of the T wave and represents the depolarization and repolarization of the ventricles of the heart. And prolonged QTC interval is also an etiology for ventricular tachyarrhythmias. Next, we have certain medications that can prolong the QT interval, such as antiarrhythmics, antibiotics, particularly macrolides, and psychiatric medications such as haloperidol, methadone, and ziprasidone. A prolonged QT interval can result in polymorphic ventricular tachycardia and Torsades de Pointes. Other conditions that can prolong the QT interval include hypothyroidism, which is also common in type 1 diabetes. Last but not least, electrolyte imbalances, which can lead to arrhythmias anywhere in the heart. The heart is more sensitive to low levels of potassium, seen in hypokalemia, low levels of calcium, seen in hypocalcemia, and low levels of magnesium, seen in hypomagnesemia. Now let's take a quick look at the pathophysiology of ventricular tachycardia. Here, ventricular tachyarrhythmias are abnormal and potentially deadly. They are caused by an abnormal ectopic contraction in the ventricle. The condition may be benign if the ectopic signal is regular and stationary and the cardiac output is maintained, but if the signal moves around the ventricle or if the rate changes rapidly, then the arrhythmia could rapidly result in cardiovascular collapse and death. Ischemic change following coronary artery disease or a myocardial ischemic event is the most common cause of VT due to the scar formation. Symptoms of ventricular tachycardia include palpitation, lightheadedness, syncope, and sudden cardiac death, especially during ventricular fibrillation. On physical exams, patients with VT will show tachycardia, and due to the low cardiac output, they may also show hypotension and tachypnea. VT is also associated with Canon A waves, and in this condition, the atria and ventricles contract at the same time to produce a strong pressure wave against the mitral and tricuspid valves of the heart. The wave may be visible passing up the jugular vein. Diagnosing ventricular tachycardia is important because these sort of tachyarrhythmias are potentially life-threatening. An ECG and physical findings are sufficient to diagnose VT. Lab studies are usually done to look for potential causes such as electrolyte imbalances, any drugs and toxins causing arrhythmias, and also taking a look at the cardiac enzymes which may be suggestive of a cardiac ischemia. The treatment can be thought from a short-term and long-term perspective. For short-term, ventricular tachycardia may result in hemodynamic collapse and require life-saving measures to restore a normal sinus rhythm. So first-line treatment is to restore hemodynamic instability. And this is done by direct current cardioversion. A stable patient with prolonged monomorphic ventricular tachycardia with no signs of end organ damage should be treated with medication-induced cardioversion with procainamide, sotalol, or lidocaine. If there is a left ventricular dysfunction, then cardioversion should be undertaken with amiodarone or lidocaine, and these antiarrhythmics are preferred because they will not exacerbate left heart failure where procainamide might. A stable patient with polymorphic ventricular tachycardia should be treated with IV magnesium sulfate, cardioversion, and an antiarrhythmic that will not prolong the QT interval. So here amiodarone is strictly contraindicated. Similar to the management of supraventricular tachyarrhythmias, if there is hemodynamic instability, direct current cardioversion, or defibrillation, if ventricular fibrillation is seen, should be carried out. For long-term therapy, the goal is to prevent ventricular tachycardia with the most effective and conservative treatment available. Treatment options include medications such as antiarrhythmics, can also perform ablation, and also an implantable cardioverter defibrillator implantation. Additionally, evaluate the QT interval and remove and change medications that may unnecessarily prolong the QT interval. Last but not least, we will take a look at the peri-arrest tachycardic rhythms and how to manage them. So let's begin by first identifying if the patient is unstable, and the signs of instability here is characterized by the presence of shock, syncope, myocardial ischemia, and heart failure. Next is to look at any adverse signs that are present and then to decide if the patient requires synchronized direct current shocks, which should be given. Treatment following this is given according to whether the QRS complex is narrow or broad and whether the rhythm is regular or irregular. In summary, tachyarrhythmias are defined as abnormal heart rhythms with a ventricular rate of 100 or more beats per minute and are frequently symptomatic. These rhythm abnormalities can be broadly classified into ventricular and supraventricular tachyarrhythmias. Signs and symptoms related to tachyarrhythmia may include shock, hypotension, heart failure, shortness of breath, chest pain, acute myocardial infarction, palpitations, and/or decreased level of consciousness. Important causes should be worked up and treated promptly, and these include coronary artery occlusion, electrolyte abnormalities, drug toxicity, and cardiomyopathies. Treatment of tachyarrhythmias is targeted to control heart rate, revert rhythm to sinus rhythm, and prevent thromboembolism. So we have come to the end of this topic. Thank you.